Congenital tracheal malformation review, thoracic master class. Introduction. Congenital malformations of the trachea include a variety of conditions that cause respiratory distress in neonates and infants. A number of anomalies are self-limiting, while others are life-threatening and requires prompt therapy. The prevalence of congenital airway malformations has been estimated to range between 0.2 and 1 in 10,000 live births. The most frequent congenital tracheal malformations are Tracheomalacia, congenital tracheal stenosis, Laryngotracheal cleft, and tracheal agenesis. Tracheomalacia. Tracheomalacia is an abnormal softening of the tracheal wall due to structural anomalies of tracheal cartilaginous and or posterior membrane. If the malacia is localized, then it is called bronchomalacia. However, the diffuse type is called tracheobronchomalacia. The condition can be congenital, either primary or acquired. Pediatric airways are characterized by increased airway compliance, resulting in excessive dynamic collapse during the respiratory cycle. Respiratory cycle is a dynamic process with inspiratory and expiratory phase. During expiration and the differential pressure changes, particularly with forced expiration, for instance, cough, the cartilaginous framework ensures that the collapse is limited to the physiological 30 to 35% of luminal production. Of note, if the dynamic collapse is bigger than 50%, some authors call the condition hyperdynamic airway collapse, and this should be differentiated from tracheomalacia, which is a true collapse or deformation of the cartilaginous rings. The common embryologic origin of the trachea and esophagus from the laryngotracheal tube explains why tracheomalacia is often associated with esophageal atresia with tracheoesophageal fistula. At the end of the embryogenesis, trachea and esophagus are fully separated, and the wall of the normal trachea is composed of C-shaped, incomplete cartilage rings anteriorly and of a muscular part posteriorly. The ratio among cartilage and floppy part of the normal trachea is around 4.5 to 1. Airway collapse due to tracheomalacia causes a large spectrum of respiratory symptoms, of which stridor, distress with cyanosis, apnea or acute life-threatening event, failure to extubate, exertional dyspnea, reduction of secretion clearance, repeated and prolonged infection, lung atelectasis, and even bronchiectasis can be the presentation. The gold standard for diagnosis of tracheomalacia is through bronchoscopy while the patient is in spontaneous breathing. Bronchoscopy is very important to explore the tracheobronchial tree with note to the vocal cord function, proximal trachea, and any other associated anomalies like cleft, tracheoesophageal fistula. Other investigational tool with non-invasive nature is the use of dynamic CT scan study, which can also give more insight about the associated vascular anomalies, tracheal diverticulum, and the peripheral bronchi and lung parenchyma. So both techniques, both tools are essential as a complementary diagnostic tool. Management could be conservative, semi-invasive, or surgical. Conservative management aim at pharmacological tools like treatment of infection, gastroesophageal reflux, and improve the tonicity of the posterior membranous part, or the use of continuous positive pressure ventilation. Tracheostomy with long arm, tracheostomy tubes, or airway stenting has been advocated. Anterior tracheopexy or posterior tracheopexy are the two techniques usually used to increase the diameter of the trachea, where the aorta is sutured to the posterior table of the sternum, or the posterior membrane is fixed to the anterior spinal ligament. The presence of complete tracheal drains along the stenotic segment is the mainstay of congenital tracheal stenosis. In the normal trachea, the cartilaginous ring are incomplete or horseshoe shaped. Congenital tracheal stenosis is associated with cardiovascular abnormalities in 69% of cases. The most common vascular association is the left pulmonary artery sling, found in 44%. Tracheal origin of the right upper lobe bronchus is found in 50% of the cases. Congenital tracheal stenosis is classified into 4 types. There's type 1, long segment stenosis, where almost all or most of the trachea is stenosed. Type 2, funnel-shaped stenosis with variable tracheal length and location. Type 3, short segment stenosis, sometimes below an anomalous right upper lobe bronchus. Type 4, anomalous right upper lobe bronchus with the bronchus to the horizontally branching bronchi to the rest of the lung. The right upper lobe bronchus is at the normal carinal level. The bridge bronchus is stenotic, and lesser stenosis may involve part of the trachea above. In general, symptoms start in a few days after birth and are associated with a severity of stenosis more than the stenotic length itself. The gold standard is the rigid airway endoscopy showing complete tracheal rings. CT scan and MRI are complementary to exclude any associated vascular malformation, and the three-dimensional reconstruction of the tracheobronchial tree provide a very good reconstruction for the tracheobronchial tree in these cases. Reconstruction of the tracheo or the tracheobronchial tree depends on the presence of respiratory symptoms. In patients with mild symptoms, some author has shown that the growth of the tracheal diameter over the year might reduce symptoms. However, patients with minimal or mild symptoms and associated pulmonary artery slings should be corrected surgically. Different technique has been advocated for the tracheal or tracheobronchial reconstruction, and this highly depends on the length of the stenotic segment. For long length segments, pericardial patch, slight tracheoplasty, tracheal autograft, and even cadaveric tracheal homograft has all been suggested. For short segment tracheal stenosis, and in children, only 1/3 of the tracheal length can be resected. This is opposite to the adult, where almost half the trachea can be resected. Laryngotracheoesophageal cleft. The laryngeal and tracheal cleft is an abnormal communication between the trachea and the esophagus. The extension of the communication is variable from a cleft at the level of the larynx exclusively to a wide communication between trachea and esophagus that may extend even to the bronchus. According to Benjamin and Inglis classification, the laryngotracheoesophageal cleft can be classified into 4 types. The first type, where the cleft is between the larynx and the esophagus above the two vocal folds. Type 2, where the cleft extends to the upper part of the cricoid. The type 3, where it exceeds the cricoid and may reach the cervical trachea. In type 4, which is the most severe part, the cleft can extend to the carina or even to the right or left main bronchi. Usually symptoms are non-specific, but most have associated respiratory symptoms and characteristically cough with early choking due to aspiration. Patient may present with airway impairment. Laryngomalacia and tracheomalacia are frequently associated. The gold standard is rigid endoscopy under general anesthesia to diagnose the cleft. Endoscopic repair is indicated for symptomatic type 1 and type 2, and even for some patients with type 3. However, the standard approach for type 3 and 4 is through the trachea, transtracheal approach, usually approaching a cervical neck incision, may be combined with mandibulotomy or sternotomy. All types of clefts can be repaired by this approach. A two-layer repair is essential, dissecting the trachea and esophageal mucosa layer and performing a closing of both mucosa separately. It is recommended to interpose synthetic fibrin, perichondrium or periosteum between the two layers. Type 4 may need ECMO or cardiopulmonary bypass to perform a complex repair down to the carina or even to one of the main bronchi. Tracheal agenesis, the cervical trachea is usually absent. The bronchus or the carina is connected to the esophagus. Floyd proposed an anatomical classification in 3 types, where type 1 represents 20%. There is agenesis of the upper trachea. Bronchus is normal. There is a tracheoesophageal fistula. In type 2, which is the most common, 60% of all cases, there is complete tracheal agenesis. The bronchus are normal, and there is a fistula between the carina and the esophagus. In type 3, the bronchus arises from the esophagus separately. Surgical repair. The presence of tracheoesophageal or bronchoesophageal fistula is important for salvage treatment of critically ill neonate with tracheal agenesis, because it allows esophageal intubation and mechanical ventilation. Esophageal intubation is a life-saving maneuver, and the distal esophageal banding and gastrostomy should be done at this